The topic of this lecture is acquired obstruction and management of the lacrimal drainage system. We'll discuss multiple pathologies in this lecture, starting with conjunctivochalasis. Conjunctivochalasis is characterized by one or more folds of redundant conjunctiva prolapsing over the lower eyelid margin. It can exacerbate the symptoms of dry eye and commonly contribute to epiphora, of which it can be an under-recognized cause. It is thought to be predominantly an involutional process involving the loss of conjunctival adhesions to underlying tenon capsule and episclera, and may be analogous to conjunctival abnormalities leading to superior limbic keratoconjunctivitis. Chronic low-grade ocular surface inflammation, for example dry eye, blepharitis, is likely to play a role if severe exposure of a redundant fold can occur. Treatment is with observation or lubricants, and they alone may be appropriate. Topical steroids or other inflammatory drugs can be used. Surgical options include securing the bulbar conjunctiva to the sclera with 3 absorbable sutures, for example 6-polyglactin, placed 6 to 8 millimeters from the limbus, or excision of a crescent-shaped area of excess bulbar conjunctiva with an interior limit of around 6 millimeters from the limbus. Suturing the edges of the excised patch together or replacement with amniotic membrane have been described. Our next pathology is primary punctal stenosis, which occurs in the absence of punctal eversion. Common causes include chronic blepharitis, idiopathic stenosis. Other causes include herpes simplex and herpes zoster lead infection, local radiotherapy, cicatrizing conjunctivitis, chronic topical glaucoma treatment, systemic cytotoxic drugs such as 5-fluorouracil, and rare systemic conditions such as porphyria and cutaneous tarda. Now, management includes dilatation of the punctum alone can be tried, but rarely gives sustained benefit. Punctoplasty is usually required. A number of techniques have been described, including 1, 2, or 3 snip enlargement, as it is shown here in the first figure, and it is a 2-snip punctoplasty, and instrument is passed through the punctum and 2 incisions are made, and post-operatively the arrows show the dilatation of the punctum. Now, the puncta are enlarged with the removal of the posterior ampullar wall, and procedure using a mechanical punch, laser, or microsurgery. A temporary stent can also be used. After this, the next is secondary punctal stenosis, which occurs after punctal eversion leading to chronic failure of tear entry, and punctoplasty is usually performed in conjunction with correction of the eversion by retropunctal Ziegler cautery, which can be used for pure punctal eversion. Burns are applied to the palpebral conjunctiva at approximately 5 millimeters below the punctum. Subsequent tissue shrinkage could invert the punctum. Other method is medial conjunctivoplasty, which can be used in medial ectropion of a large area of the lid if there is no substantial horizontal laxity. A diamond-shaped piece of tarsoconjunctiva is excised about 4 mm high and 8 mm wide, parallel with and infralateral to the canaliculus, as it is shown in the figure, followed by approximation of the superior and inferior wound margins with sutures. Incorporation of lower lid retractors in the sutures further aids repositioning. Now, this helps a lot. Now, the next method is lower lid tightening, usually with a tarsal strip, is used to correct lower lid laxity and may be combined with a medial conjunctivoplasty, where there is a significant medial ectropion component. Next pathology is canalicular obstruction. Causes include congenital, trauma, herpes simplex infection, drugs, and irradiation. Chronic dacrocystitis can cause a membrane to form in common canaliculus. The initial surgical approach has tended over recent years to attempt to preserve the physiological anatomy. Now, partial obstruction of the common or individual canaliculi or anywhere in the lacrimal drainage system may be treated by simple intubation of one or both canaliculi with silicone stents. These are left in situ for 6 weeks to 6 months, as they are shown in the picture here. The stent is placed here. Within that, total individual canalicular obstruction, canalicular trephination using a purpose-made mini trephine, which is sizzler followed by intubation. Trephination has also been described using an intravenous catheter with a retracted introducer needle used as a stent and then advanced to overcome the obstruction. Balloon canaliculoplasty and endoscopic laser techniques are available. The less invasive options may have lower success rates than more aggressive surgery. With 6 to 8 millimeters of patent normal canaliculus between the punctum and the obstruction, anastomosis of a patent part of the canaliculus into the lacrimal sac with intubation can be performed. Where obstruction is severe or it is not possible to anastomose functioning canaliculi to the lacrimal sac, conventional surgery consists of conjunctivodacrocystorhinostomy and the insertion of a Tuchman glass, which is Lester-Jones tube. This may also be used when the lacrimal system is intact but non-functioning due to failure of the physiological thumb, for example in cases of facial nerve palsy. This is a picture of the Lester-Jones tube, and this 3D CT scan shows us the placement. The surgery is performed as for an external approach dacrocystorhinostomy, but the caruncle is excised and a track for the tube created between the lacus lacrimalis and the lacrimal sac. Patient satisfaction is variable. Coming up next is the nasolacrimal duct obstruction. Causes include idiopathic stenosis, which is by far the most common cause, nasoorbital trauma, including nasal and sinus surgery, and granulomatous disease, such as granulomatosis with polyangiitis, Wegener's disease, and sarcoidosis, infiltration by nasopharyngeal tumors. Treatment is with conventional external approach dacrocystorhinostomy. Now, technique of the surgery is quite complicated, but I am trying to explain it. Conventional external approach dacrocystorhinostomy is indicated for obstruction distal to the medial opening of the common canaliculus and consists of anastomosis of the lacrimal sac to the mucosa of the middle nasal meatus. The procedure is usually performed under hypotensive general anesthesia. A vertical skin incision is made 10 millimeters medial to the inner canthus, as it is shown here, the vertical skin incision. The medial canthal tendon and the lacrimal sac exposed and reflected, and after removal of intervening bone, the sac is incised and attached to an opening created in the nasal mucosa. The success rate is over 90%, but causes of failure include inadequate size and position of the ostium, unrecognized common canalicular obstruction, scarring, and the sump syndrome, in which the surgical opening in the lacrimal bone is too small and too high. Complications include cutaneous scarring, injury to the medial canthal structures, hemorrhage, infection, and cerebrospinal fluid rhinorrhea if the subarachnoid space is inadvertently entered. The other option which is available to us is endoscopic TCR, which encompasses several techniques. A light pipe can be passed through the canalicular system into the lacrimal sac to guide an endoscopic approach. From within the nose on a microendoscopic transcanalicular procedure can be performed using a drill or a laser to establish communication with the nasal cavity. Advantages over the conventional DCR include less marked systemic disturbance with minimal blood loss and the low risk of CSF leakage, the avoidance of a skin incision, and generally a shorter operating time. But that depends on your experience. Disadvantages include generally a slightly lower success rate and visualization difficulties, meaning that additional procedures are sometimes needed. Other procedures often reserved for partial nasolacrimal duct obstruction include probing and intubation, stent insertion, and balloon dacrocystoplasty. Last but not the least is the dacrylithiasis. Dacroliths, which are lacrimal stones, may occur in any part of the lacrimal system. They are more common in males, although the pathogenesis is unclear. It has been proposed that tear stagnation secondary to inflammatory obstruction may precipitate stone formation, which tends to be associated with squamous metaplasia of the lacrimal sac epithelium. Presentation is often in the late adulthood. Symptoms may include intermittent epiphora, recurrent attacks of acute dacrocystitis, and lacrimal sac distension. The lacrimal sac is distended and relatively firm, but is not inflamed and tender as in acute dacrocystitis. Mucus reflux on pressure may or may not be present. Treatment involves TCR. So this is it with the acquired obstruction. We'll discuss congenital obstruction in the next lecture. Thank you all for listening. If you like the lecture, please press on the like button and subscribe to the channel.